You sent over some really compelling information on sickle cell disease, and one statistic really jumped out at me.
Oh, yeah. Which one?
In the U.S., about 1 in 325 black newborns has it. That immediately makes you think, wow, okay,
Yeah.
that's more common than I realized. What's the story there?
Exactly. It's significant.
So based on the information you shared, that's really what we want to explore in this deep dive, right? The why and the how behind it.
Precisely. The material gives us a great foundation. We're going to focus mainly on sickle cell disease, specifically hemoglobin SS disease, which most people know as sickle cell anemia or SCA.
Okay, SCA.
Yeah, we'll look at, what it is, the causes, the complications people might face, how it's generally managed, and some key nursing considerations from the sources.
And our goal here, it isn't just to, read off facts from the sources. We want to pull out the really important stuff.
Make it clear, understandable.
Exactly. Unpack the complexity, but, without drowning everyone in jargon. So let's start big picture. What exactly is sickle cell disease?
Okay, good place to start. So sickle cell disease, it's not just one thing. It's actually a group of inherited blood disorders.
Oh, okay.
And the common link is the hemoglobin. In SCD, the red blood cells carry an ineffective type of hemoglobin instead of the normal adult kind HGBA.
Right.
Now, in the U.S., the most common types are the one we're focusing on, HGB-SS disease, sickle cell anemia, but there's also HGB-SC disease, and hemoglobin sickle beta thalassemia. And it's important to note, these conditions predominantly affect people whose families originate from certain parts of the world: Africa, the Mediterranean, the Middle East, and India.
Okay, so several types, but we're really zeroing in today on sickle cell anemia, the HGB-SS type.
Yeah.
What makes that one, well, the focus?
Well, HGB-SS is the most severe and often the most common form. And the key difference, it's tiny but huge in impact. It's molecular.
Molecular.
Yeah. So normal adult hemoglobin is HGB-AA. The A is for adult. In sickle cell anemia, it's HGB-SS. The S stands for sickle. And this change happens because just one single amino acid is different in the hemoglobin molecule. Glutamic acid gets swapped out for valine.
Just one. That seems minor.
It sounds minor, but it has massive consequences for the red blood cells. That one change affects the shape and flexibility.
How so?
Instead of being nice and round and flexible, able to squeeze through tiny blood vessels, the red blood cells become, elongated, rigid. They take on that classic crescent or sickle shape. Your figure 46.7 shows it well.
Right, I saw that image. They look sharp, almost.
Yeah, and they're stiff. They also don't live as long as normal red blood cells. And going back to the stats, that 1 in 325 black newborns number, that largely refers to SCA HGB-SS.
Okay, that makes sense. Now, the materials also mention sickle cell trait. How does that fit in? Is that the same thing?
No, and that's a really crucial distinction. Sickle cell trait is different. Someone with the trait has a mix. They have both normal hemoglobin HGBA and sickle hemoglobin HGBS.
Ah, so a mix.
Exactly. Genetically, we call it heterozygous. Their designation is HGBAS, and it's much more common than SCA. About 1 in 13 black newborns have the trait.
Wow. Okay, so what does that mean for their health?
Generally, people with sickle cell trait have minimal, if any, health problems directly related to the sickling. They carry the gene, but they don't typically experience the disease itself. It's important to know the difference.
Okay, so disease is HGB-SS, trait is HGB-AS. Got it. How is the disease, SCA, actually inherited then?
Right. So inheritance, SCA, is passed down through what's called an autosomal recessive pattern.
Autosomal recessive.
Meaning you need to inherit the specific gene, the HGBS gene, from both parents to have the disease.
Both parents, okay.
Typically, this means both parents have sickle cell trait. They're HGBAS. They are carriers. They don't have the disease, but they can pass the HGBS gene to their child.
And if both parents are carriers?
Then, with each pregnancy, there's a 25% chance the child will inherit SCA, HGBSS. A 50% chance they'll have sickle cell trait, HGBAS, and a 25% chance they'll inherit 2 normal genes, HGBAA. Figure 46.8 lays this out.
Okay, that clarifies the probability.
Yeah.
You also mentioned something interesting. Newborns don't show symptoms right away.
That's right. Infants with SCA are usually asymptomatic for the first few months, maybe till 3 or 4 months old.
Why is that?
It's because they still have a significant amount of fetal hemoglobin, HGBF. And HGBF doesn't sickle like HGBS does. It sort of protects them for a while.
Ah, so it's when the HGBF levels drop and the HGBS takes over that the problems start.
Exactly. That's when the clinical manifestations begin to appear. And unfortunately, those problems, the complications of SCA, can be really varied and quite serious.
You listed quite a few in the notes. Let's talk about those.
Yeah, the list is long. There are the recurrent vaso-occlusive pain crises. That's probably the hallmark symptom people think of. Intense pain.
Right.
But also, there's a higher risk of stroke, even in children. Sepsis, which is a dangerous body-wide infection. Acute chest syndrome, that's a big one. Sickling in the lungs.
That sounds incredibly serious.
It is. Then there's splenic sequestration, where blood gets trapped in the spleen. Problems with vision, chronic leg ulcers that are hard to heal, gallbladder issues like cholestasis and gallstones.
Wow. It affects so much.
It really does. Delayed growth and development, delayed puberty are common. Priapism, which is a prolonged, painful erection due to blocked blood flow. And something maybe less known, kids with SCA often have issues with enuresis or bedwetting.
Why bedwetting?
It's because the kidneys have trouble concentrating urine properly, another effect of the impaired blood flow over time. And sadly, as individuals with SCA grow older, multiple organ dysfunction becomes increasingly common.
It's really systemic then, not just a blood issue. It hits almost everywhere.
Absolutely. That single amino acid change really triggers a cascade affecting the entire body.
So that paints the picture of what happens. Let's dig into the why, or the how. What's the underlying process causing all these complications? The pathophysiology.
Okay, the how. Fundamentally, it comes down to the sickling itself. When enough red blood cells sickle, it can cause significant anemia just not having enough healthy red blood cells.
Right, anemia.
And certain conditions can trigger more sickling. Things like getting an infection, running a fever, being dehydrated, intense physical exertion, getting too cold, or having low oxygen levels, hypoxia.
So those are triggers to avoid, presumably.
Definitely. Now, what happens during sickling? Figure 46.9 shows this well. The sickled cells, being rigid and sticky, they clump together.
Okay.
This clumping increases the blood's viscosity, makes it thicker, and physically blocks normal blood flow, especially in the tiny blood vessels, the capillaries, and venules. This is vaso-occlusion.
Vaso-occlusion. Locked vessels.
Exactly. And that blockage means tissues downstream don't get enough oxygen. That's local tissue hypoxia. This leads to ischemia, which is insufficient blood supply, and potentially even infarction tissue death.
And that's what causes the pain crises. The ischemia.
Precisely. That lack of blood flow, especially in places like the joints, is what causes that severe pain, and it can become a vicious cycle.
How so?
Well, the pain itself increases the body's metabolic need, your heart rate goes up, maybe you breathe faster, and the stress can actually cause more sickling.
Oh, wow. Okay. What about acute chest syndrome? How does that work?
Acute chest syndrome is when that vaso-occlusion, that clumping, happens in the blood vessels of the lungs.
No lung, so...
That dramatically reduces gas exchange. Oxygen can't get in properly, carbon dioxide can't get out. This leads to hypoxia, which, again, triggers more sickling. It's a medical emergency and, like we mentioned, a leading cause of death in kids with SCD.
That sounds terrifying. And splenic sequestration.
That's another acute issue. A large amount of blood suddenly pools in the spleen because it gets trapped there by sickled cells. The spleen swells up rapidly, causing abdominal pain, and it can lead to a severe drop in hemoglobin, life-threatening anemia.
So the spleen is heavily involved.
Very much so. And there's a longer-term process, too. The constant breakdown of these damaged red blood cells, hemolysis, causes chronic anemia. The spleen works overtime trying to filter out these sickled cells.
Right.
Initially, this makes the spleen enlarge splenomegaly. But over years of this, usually in early childhood, the spleen gets damaged, scarred, fibrotic, and eventually it just stops working properly. That's functional asplenia.
No spleen and that loss of spleen function. That's why infections are such a big risk.
Exactly. The spleen is crucial for fighting certain bacteria, especially those nasty encapsulated ones like Streptococcus pneumonia. Without a working spleen, the body's defense against them is severely weakened.
Which explains why preventing infection is so central to managing SCA.
Absolutely. Therapeutic management really revolves around a few key goals: preventing those vaso-occlusive episodes, preventing infections, and managing other complications. Given that huge risk from strep pneumo due to functional asplenia, things like prophylactic antibiotics, usually penicillin started very early in infancy, are standard practice. And staying on top of all the recommended immunizations is just critical.
So prevention is huge.
Mm-hmm.
But what about when a vaso-occlusive crisis does happen? How is it treated?
Right. Managing the crisis, the absolute first priority is pain control. Intense pain. We need to manage that effectively, also because, as we said, Pain can worsen sickling.
Okay, pain relief first.
Then, oxygen. Even if oxygen levels aren't critically low, supplemental oxygen can help prevent further sickling. Hydration is also key, often intravenous, or IV fluids are needed to help thin the blood and improve flow.
Makes sense.
Doctors will closely monitor blood counts, hemoglobin, hematocrit, and the reticulocyte count, which shows how many new red cells are being made to see if a blood transfusion with packed red blood cells, PRBCs, is needed.
And electrolytes, you mentioned those.
Yes, monitoring electrolytes is important too, because sometimes when transfused blood cells break down, or just from the illness itself, imbalances can occur. And naturally, if an infection is suspected or confirmed, antibiotics are started immediately.
Your notes also mentioned some other treatments in box 46.3, hydroxyurea, L-glutamine.
Right. There are other medical strategies. Some patients benefit from medications like hydroxyurea, which works by increasing the production of fetal hemoglobin, HGBF, remember, that type doesn't sickle.
Boosting the protective kind.
Exactly. L-glutamine is another medication that can help reduce the frequency of crises. Blood transfusions are used for specific situations, like severe anemia or before certain surgeries. For very severe events like stroke or acute chest syndrome, a procedure called partial exchange transfusion might be done, where some of the patient's blood is removed and replaced with healthy donor blood.
And stem cell transplant.
Hematopoietic stem cell transplant, HSCT, is the only potential cure currently, but it carries significant risks and is usually only an option for children with severe SCA who have a perfectly matched sibling donor. It's not a common treatment.
Okay, that gives a good sense of the medical side. Let's shift to nursing assessment. What are the key things a nurse would look for when caring for a child with SCA?
Nursing assessment has to be really thorough, head to toe, because SCA touches so many systems. It starts with a detailed health history.
Like what kind of details?
You'd want to know about their growth and development patterns, how often they usually have pain crises, how severe they are, past hospitalizations, what pain treatments worked or didn't work before.
Okay.
Their immunization status, history of blood transfusions, current medications, any history of frequent infections. And if they're in a potential crisis, you'd ask about possible triggers, fever, dehydration, recent exertion, and get a really detailed description of their current pain. Where, when, what it feels like, what helps, what makes it worse.
Got it. And then the hands-on physical exam. What are the signs?
Physically, you're observing carefully, looking for paleness, especially in the conjunctiva, inside the eyelids, palms, soles of the feet, overall skin tone, any skin lesions or ulcers, particularly on the legs, checking for jaundice yellowing of the skin or the sclera, the whites of the eyes, looking inside the mouth for color and moisture. Taking their temperature fever could mean infection. Checking blood pressure might be low with severe anemia, or high if kidneys are involved.
Neurological checks, too.
Absolutely critical. Assessing their baseline mental status and doing regular neurochecks because of that stroke risk. Then listening auscultation. Listening to the heart for murmurs or a fast rate, which could be pain, fever, or dehydration.
And the lungs.
Listening very carefully to breath sounds, the rate, depth, how well air is moving, any abnormal sounds like crackles or wheezes that might point to infection or acute chest syndrome.
What about palpation, feeling things?
Yes, feeling the joints for warmth, swelling, tenderness, checking range of motion, gently feeling the abdomen for tenderness, or to see if the liver or spleen feel enlarged.
And there was a specific alert about infants.
Yes, a key clinical reasoning alert. If an infant or toddler presents with symmetric swelling of both hands and feet, it looks like little sausages. That's called dactylitis. It's often the first sign of vaso-occlusion caused by infarction in the small bones of the hands and feet, like in figure 46.11. That needs to be reported immediately.
Okay, dactylitis, important early sign. What about the lab tests? We touched on them, but how do they guide care?
Labs are crucial for diagnosis and ongoing monitoring. As mentioned, newborn screening is mandatory everywhere in the U.S. now.
That's good, early detection.
Definitely. But the initial screen, often called sickle dex or sickle prep, it just tells you if HGBS is present. It doesn't distinguish between sickle cell trait, HGBAS, and sickle cell disease, HGBSS.
Oh, okay, so you need another test.
Yes. Hemoglobin electrophoresis is the definitive test. That's what confirms the diagnosis. In a young infant with SCA, it will show mostly HGBS and some HGBF. In an older child or adult with SCA, it will show predominantly HGBSS.
And for ongoing monitoring, what are the typical lab findings?
You'll typically see a lower than normal hemoglobin level, often baseline between 7 and 10 milligdl, but it can drop much lower during a crisis.
Okay.
The reticulocyte count, measuring new red blood cell production, is usually greatly elevated because the bone marrow is working overtime to compensate for the rapid destruction of sickled cells.
Makes sense.
A look at the peripheral blood smear under the microscope will show those characteristic sickle-shaped cells and often target cells. Platelet counts are frequently increased. The ESR, or erythrocyte sedimentation rate, a marker of inflammation, is usually elevated, and liver function tests might be abnormal, especially with elevated bilirubin from all the red cell breakdown.
And imaging,
Yeah.
x-rays and scans.
Yeah, those are used more to assess for complications, looking for signs of organ damage, like changes in bones from a vascular necrosis, checking the lungs during suspected acute chest syndrome, or looking for gallstones.
So putting it all together, the history, the exam, the labs, how does nursing management approach this complex condition?
Nursing management really aims for a holistic approach. The big focus areas are trying to prevent crises, educating the child and family, managing pain effectively when crises do occur, and providing psychosocial support.
Support seems really key.
Hugely important. And because SCA can impact development, nurses also keep a close eye on growth, developmental milestones, and school performance, looking for any early signs of issues, like neurodevelopmental delays, so interventions can start early. It's all about tailoring the care plan to that individual child and family.
Education sounds like a cornerstone of that plan.
Absolutely fundamental. Right from diagnosis, families need education. About the genetics, encouraging carrier testing for other family members is important. About the disease process itself, what's happening and why.
Right.
The importance of regular health visits, keeping up with immunizations, how to give the prophylactic penicillin correctly, and any other prescribed meds like hydroxyurea or L-glutamine. And crucially, knowing the signs that require immediate medical attention, especially fever.
The teaching guidelines 46.3 you mentioned cover preventing crises.
Yes, they provide practical advice on recognizing triggers and signs of vaso-occlusive events. Nurses also educate families about potential long-term complications to watch for as the child grows, things like delayed growth or puberty, stroke symptoms, gallstones, vision changes, hip or shoulder pain suggesting a vascular necrosis, priapism, leg ulcers.
That's a lot for families to manage.
It is, and that's why providing age-traumatic care is also important for the child, using age-appropriate distraction, teaching coping skills, making procedures as comfortable as possible.
Let's circle back to pain management during a crisis. You said it's crucial. What are the key principles?
Okay, pain crisis management. Number 1, assess pain thoroughly and regularly using a standard scale appropriate for the child's age. Number 2, believe the child's report of pain. Always.
Believe the child's got it.
For moderate to severe pain, opioids are usually the mainstay. Often they're given on a fixed schedule initially, around the clock, to get the pain under control, rather than waiting for the child to ask. PCA, patient-controlled analgesia, can be great for older kids and teens.
You mentioned a note about opioid misuse.
Yes, it's an important point from the sources. While opioid addiction is always a concern with chronic use, studies suggest the rate of misuse among individuals with SCD is actually lower than in some other chronic pain populations. That shouldn't prevent adequate pain relief.
Good to know.
Yeah.
What else besides opioids?
Hydration. Aggressive hydration, usually with hypotonic 5V fluids, is critical to help reduce blood viscosity. For less severe pain, or as an adjunct, NSAIDs, non-steroidal anti-inflammatory drugs, or acetaminophen can be used.
And then non-drug methods.
Definitely. Non-pharmacologic techniques are very important too. Distraction, relaxation techniques like deep breathing or hypnosis, music therapy, gentle massage, therapeutic play, guided imagery, therapeutic touch, behavior modification, all can help manage pain and coping.
And the warning about meperidine.
Yes, worth repeating. Avoid meperidine, Demerol, for sickle cell pain. With repeated doses, a toxic metabolite can build up and increase the risk of seizures.
Okay, so manage the pain, hydrate.
Right.
What else during a vaso-occlusive episode?
You also need to address any underlying triggers, like treating an infection if one is present. Manage fluid volume carefully. We talked about increased intake, aiming for maybe 150 millil per kilogram per day, or even double maintenance fluids, orally if possible, IV if not, to promote hemodilution.
Maintain balance too.
Yes, keeping electrolytes and acid-base balance in check is important. And constantly monitor for ineffective tissue perfusion. That's the core problem. Frequent respiratory checks, circulatory status checks, pulses, capillary refill, skin temperature.
Incidence spirometry.
Yes, encourage use of the incentive spirometer, especially if they're in bed a lot, to help keep the lungs expanded and prevent atelectasis and acute chest syndrome. Give oxygen if saturation drops below 92%. But remember, routine oxygen if they're not hypoxic isn't needed and might suppress red cell production. And report any change in consciousness immediately.
We keep coming back to infection prevention. What are the specific nursing actions there?
It's drilled in because it's so vital. Daily oral penicillin v potassium prophylaxis, starting by 2 months old, continued until at least age 5, is standard. Erythromycin, if they're allergic to penicillin.
And vaccines.
Strict adherence to the full recommended childhood immunization schedule, plus specific additions for SCD, the full pneumococcal 7-valent series in infancy, followed by the 23-valent pneumococcal vaccine annually after age 2. Also, the meningococcal vaccine series and an annual flu shot after 6 months of age.
It really underscores how vulnerable they are to certain infections.
Extremely. That functional ascleria makes common bacteria potentially life-threatening.
It's clear that living with SCA requires so much support, not just medically, but emotionally and socially.
Absolutely. Families need immense support. They might grapple with feelings of guilt or responsibility because it's inherited. Providing reassurance, ongoing education, and connecting them with resources is key. Referral to comprehensive regional SED centers, like mentioned in Evidence-Based Practice 46.1, is highly recommended because they offer that multidisciplinary team approach. Doctors, nurses, social workers, psychologists, genetic counselors, all working together.
So, wrapping up this deep dive, it really seems the core issue in sickle cell anemia, this HGB-SS disease, traces all the way back to that single, tiny alteration in the hemoglobin gene.
That's the crux of it. One amino acid change leads to this cascade. Sickled cells, vaso-occlusion, anemia, organ damage, pain, all the diverse complications we've talked about. It's incredibly complex.
Which means management has to be multifaceted too.
Exactly. Preventing problems whenever possible, managing acute episodes aggressively, and providing continuous supportive care throughout their lives.
And thinking back to that initial statistic, the prevalence, it really underscores the impact this condition has on individuals, families, and whole communities. Understanding these mechanisms, even at this level, feels so important for effective care and just general health awareness.
It really does. And, delving into SCA, this highlights the body's interconnectedness. When you see how one genetic change can ripple through nearly every organ system, it poses broader questions.
Like what?
Well, what does studying a complex multi-system illness like SCA teach us about managing other chronic conditions? And looking forward, especially with the genetic basis being so clear, how might continued advancements in gene therapies or other targeted treatments reshape the future for people living with sickle cell disease? It makes you think about where things might be heading.